Is anyone there?
Hi, this
Brian.
is Sharon in Tucson. I can hear
Okay.
This is Ryan Harold. I'm here.
Good morning, Shelley. Rebecca Harrow's on the phone again.
Kelly, are you ready to get started? This is Amber.
In the 90s.
Okay, Ben gave me the thumbs up to get started, so we'll call the Education Committee meeting to order. Shelley, if you want to do the roll call.
Is anyone else on the line having difficulty hearing anything?
I can't hear Shelley.
I can't hear Shelley.
I can't hear Shelley. Yeah, Kingman's
I
on
hear all
too.
of you.
Hey, Rebecca, it's Ed in Sedona. I can hear everybody on the conference fine but Shelley.
Okay.
Same.
Oh, we figured it out.
Yay. Thanks.
Okay.
We're in a different space because we got kicked out of our building, so thanks for your patience.
It's a very fancy room with very space age buttons.
All right, Amber Rice, I have you as present. Brian Smith, I have you as present. Chester Key. And I have Ed Mazulis as present. Is Josh Gaither on the phone?
Yes, I'm here.
Chris Long,
Yes, I'm here.
Matt Shaw,
Present.
Orlando Alcordo, Paul Honeywell, Ryan Harold,
Here, present.
Sandy Nygaard,
Here.
Darren Hollingsworth,
Yes, I'm here.
and Stevie Merrill.
Stevie Merrill's on. And Chester Key is also on.
All right, I'm counting 11. We do have quorum.
Thank you, Shelley. Moving on with the rest of the chairman's report. So the attendance report is attached to the packet. As a reminder, if you miss 2 consecutive meetings, the Bureau will contact you and ask if you're still interested in serving the committee. For the next item on the report, we have a new member, Stevie Merrill. So she's from Western Arizona Council of EMS representative. She's out in Kingman. So welcome, Stevie. Thank you for joining us.
Yeah, thanks for having me.
So next item in the chairman's report is the training module review. So if you look at the other attachment, we have some training modules that have been created by our work groups. Some of them are up for review and revision. So we have the ones that are most out of date on there, or next up for review be the chest compression only CPR, the sepsis, and the medical decision-making capacity, which was in 2017. So all of those were up either in 2019 or January of 2020. So I thought that we wouldn't need an entire work group to meet a whole bunch to revise these because they're already completed. But what I was hoping was to get a couple volunteers for each one to review the content, make sure that it's up to date, and then maybe just provide me with the updates, and I'd be happy to compile those into some revisions that we can bring back to the committee. So I was hoping maybe I would get a few people that would be willing to volunteer some of their time to at least just review 1 or 2 of the modules.
This is Sandy. I'll be happy to review the sepsis module.
This is Brian. I'll do decision making.
This is Ryan Harold. I can do whatever one is needed.
This is Stevie Merrill. I can do one also.
Okay, so if anybody else, we'll send an email out to the group with those attachments. And then whoever is willing to take a look at those and just send some feedback and items back to me, I'd be happy to compile those into one reviewed document for each one of the modules. And then looking forward, there's the VAD, Life Vest, and Stop the Bleed resources also, which I'd probably address in the next sort of coming up later. So thank you guys for volunteering. The next item is the education bylaws, which are for review in 2020. So I don't know if Terry's still on, but what he had.
Amber, this is Dale. I'm sorry, I called in a little bit late.
Yeah. Thank you, Dale.
I'm sorry, I called in a little bit late, but if you're looking for volunteers, I can look at the room.
Be up for review in March of 2021. So we have a little bit of time on that one. But if you want to take a look at it, if you think something's changed significantly, I would definitely appreciate someone taking a look at it.
Will do.
Thank you. Next item on the agenda is the education bylaws due. Terry had mentioned in the previous meeting that they're going to try to coordinate this across all of the standing committees and put together a process so that it'll be the same across all the standing committees. So we'll be hearing from the Bureau about that. As far as I know, is that correct, Terry?
I think both he and Gail had to get step out for an EOC
meeting. Yeah, sounds good. And if we move on to the rest of the agenda, we have the Bureau report. What I have on here for today is EMS for Children, Julia.
Hello. So most notably for this group is that we did last time approve the development of a safe sleep work group. So the work group has met twice. Once as a larger group, second to kind of develop the slides. So the slides and a toolkit are in the process of being developed. We decided to develop approximately a 30-minute PowerPoint that could just be posted on the ADH webpage, and then provided the credit for that. Yeah, so we'll continue to do that. Hopefully we'll have those for review by the Education Committee by the next round of committee meetings. That's all.
Cool. Thanks, Julia. Anything else from the Bureau, Ben?
Nope, that's pretty much it.
Okay, I do have just a couple of action items on here for today. The first one is to discuss and approve the EPCR training attachment. So if I have a motion to discuss the EPCR training.
So moved.
I second. This is Matt.
And Brian was,
Hang on one second, Amber. We gotta, I think, Shelley needs us to go back and do the last meeting's minutes real quick.
Oh, you're right. That's fine. So why don't we review last meeting's minutes? Shelley has them up on the screen for those of you online. I'll take a motion to approve the minutes as soon as somebody's ready.
so moved, Brian.
This is Matt.
Second,
I
Sandy.
second.
Thanks, guys. All in favor of accepting
Was
the
that-
meeting minutes?
Aye.
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 Opposed, say nay. Okay, so with that, we'll accept the meeting minutes from the last meeting. Now to move on to the action items. I think I already had a motion and a second. So we'll take a look at the attachment that Shelley has up, which is the education PowerPoint for what should go in your EPCR. So I went through some of this with Prosper and kind of made a few recommendations, but we can kind of go through them slide by slide and see if anyone has any additional thoughts or comments. It's not a very long PowerPoint. So Shelley, if you want to.
Sorry, this is Ben, just a little bit of background for the group. So we had previously retitled this PowerPoint, what should go in your EPCR, just as some kind of how to document things that would be beneficial for documentation. And then with the development of the Cactus scoring system, we wanted to incorporate things that would help improve agencies' Cactus score with their documentation. So this is just that same PowerPoint, and we've just included a couple small additions that we hope will improve agencies' Cactus score that was based on feedback from our most recent EMS-RUG meeting. So at EMS-RUG, we got a little bit of feedback about what should be incorporated for scoring that went to TEPI, and then we also got a little bit of feedback from agencies who have kind of done some of the legwork to try and improve their scores, and we are trying to incorporate that in this educational PowerPoint.
Thank you, Ben. So in the objective slide, I have a couple of recommendations to talk about educate field personnel of data mapping and importance of data completeness, because the PowerPoint does discuss primarily data completeness and things to help with that. As well as key EMS benchmarks. Really the ones we're talking about in here are for the time-sensitive illness and injuries specifically. So we don't go over all key EMS benchmarks. The ones that are specifically talked about in this are the time-sensitive illness and injuries. So I recommended to clarify that in the objectives. Want to go to the next slide, Shelley? In the definitions, I don't know if anyone has any specific recommendations. I didn't see anything that needed to be added to the definitions. This one specifically, the recommendation I had for this one was to talk up for the AZ Share one, clarify that it is the Arizona registry for out-of-hospital cardiac arrest. So it's not all cardiac arrest patients in Arizona, but out-of-hospital cardiac arrest and then clarify that it's linked with our hospital outcomes. I think you should. For this one here, the National EMS Registry Database, I'm not sure what this 90% refers to. Ann and I couldn't figure this out. If anyone knows where that comes from, that'd be helpful. Ben, do you have something on that?
Nope, that's a good point. I don't.
Okay.
Yep.
Yeah, not sure what that means. So I just recommended taking that out. And then on the next slide, I don't think I have anything on the slide. It just comes directly from the NEMSIS website about what the goals and objectives are of NEMSIS. And then here we have some additions based on
I gotta go meet my new battalion. I told them I was at Desert, thinking that they would not be anywhere in the area.
So this one for time-sensitive illness and injuries, just to be consistent with our terminology, STEMI, stroke, trauma, cardiac arrest, and then adding in the opioid data elements and select pediatric data elements. I didn't know if there was a better way to say that, since all included in the Cactus data set.
Okay. It's Brian.
Yeah, Brian.
So is the opioid information really a time-sensitive illness and injury, or should that just be like a separate bullet point? And then my other question would be, should we be, since I don't do any of the input, would sepsis be a part of that? Or is that just because, or that's not related to Cactus data set, it just wouldn't go in there?
So right now, Brian, I would say because it's not a Cactus, we've kind of talked about it, but right now, because it's not a Cactus element, I would say not yet.
Okay. That was it.
And just for the group, I know we're displaying you're seeing the track changes on the side. Just for the group, we're only discussing the addended changes in red on the slides. That's what you would be approving changing.
Yeah. Any other comments or additions, please feel free to chime in. And then national benchmarks. I don't know how relevant this is, but states that some of the benchmarks come from recommendations from NHTSA and other stakeholders. The next slide, I had some more significant additions to, so that it a little bit more about what Cactus is. And we've removed pending. I removed pending from Cactus tying to PEEP, although we haven't really determined what our sort of threshold necessarily is going to be. We've been discussing that obviously in the TEPI committee. Those have not gone through EMS Council yet, so I left that off of there and just said that it is tied to PEEP recognition. So if anyone has any other comments for that, we'll move on to the next slide. So why data completeness matters. So the first bullet point is to discuss the linkage of EMS calls to patient outcomes. So currently those that participate in the HIE are able to retrieve selected patient outcomes that are provided by the hospitals. So there obviously is a limitation to that. But on the EMS side, data completeness certainly can be a limitation to being able to retrieve the HIE outcomes. So it's important from that perspective. And then we talk about organizational comparisons, the aggregate and individual data quality reports. And in discussing this with Ann, it sounded like that, agencies could get these reports, but that we're only guaranteeing them really for the PEEP agencies. So I don't know if anyone else has speak to on that, or if the way I've worded it is correct. That sounds right. Ben's gone. And then
I keep forgetting to hit my mute button and turn my mic back on.
That's okay.
Yes, that does seem correct.
Okay. And I couldn't find anywhere where it affects funding for agency and state. I didn't know what that referred to at all, and I couldn't find any reference that data completeness would affect funding for the agency or the state.
So that came from an older version of this PowerPoint. I think broadly we're trying to explain to paramedics that we've seen a couple examples where EMS agencies are trying to either explain to city councils what they do or apply for grants or apply for funding, and they've needed to provide data to their grant application or to their city council, and they don't, it becomes readily apparent that the historical data or call information or something to that effect is important when they go to fill out that application and it's not there. There may be a better way to say that, but yes, you are correct. It is not, you don't get paid by the PCR.
Okay.
This is Brian.
Yeah, thanks, Brian.
Is the linkage between HIE and AZ peers, is that full blown right now, or is that still on a pilot? Because I thought it was in a pilot.
It is, so I've got to choose my words carefully here. It's up and running. Anyone can participate. We're just enrolling agencies as they would like to participate, not all at once, because we want to make sure that the data is kind of high quality, and we're kind of learning as we go. Right now we have, I believe it's 6 or 7 agencies participating. As we get more and more agencies participating, we're kind of learning, we're kind of ironing out some wrinkles. But yes, it is up and running. An agency who wants to participate can sign up today.
Okay.
And then in the next slide, so obviously creating benchmarks, performance measures, and then for reimbursement. I wasn't sure what this meant by income for personnel. This initial slide, but that part was unclear to me what that meant, other than being sort of important for billing generally.
I think this is similar to kind of what I described earlier, which is broadly and kind of historically, we were just kind of, when this document was created, just explaining that, actually, I'm not sure where income, if you would like, if the group is okay with it, we can certainly strike that bullet point.
I recommend striking it just because I don't think if someone's using this PowerPoint to teach, they're going to be able to easily explain what that means.
I agree. That's a billing question for sure.
And then obviously data completeness for like grant opportunities, and if you had to show completeness for certain elements, it would be important for certain grants. So that one to leave in there. The slide is about the data mapping. So really just to talk about sort of the flow of data through the EMS call. I think what this slide mostly points out is that elements put into the narrative only are not going to get recorded in the appropriate locations, and they would fall out of AZ peers and therefore NEMSIS data sets if only captured in the narrative. That's what this data mapping slide basically shows. This one, there's this slide and then there's the next slide. So I basically just rebuilt this slide. If you want to go to the next one, Shelley, just to make it more, just to sort of take out some of the extra wording in it. And then added in the HIE component of it that's, has been launched and that we're working on right now. So we probably recommend replacing the previous slide with this one just because it's a little less wordy. And then the next slide, the core data elements. So some of this just came from the previous discussion about the data completeness in the Cactus data set. And some of the things that have been noticed to have completeness percentages. So age and vital signs don't seem to be as big of a problem. So I recommend sort of striking these out as highlighting them as crucial elements. Some of the other ones, such as possible injury, current medications, allergies, response to procedure, pulse ox and respiratory rate, in some of the areas had lower completeness percentages. So I just added these in here to highlight them. And then the race and ethnicity one typically has low completeness percentages. I only left it in here to point out that for opioid reporting, it's technically a statutory requirement to complete that data field. So everyone has thoughts about this one. This is me just putting in things that we may want to highlight as they were ones that we were highlighting in the data completeness for the Cactus data set. Next one is the entitled CO2. So again, just highlighting a field that is a standard of care, but in the data completeness looks to be a relatively low percentage for something that's considered a critical patient safety indicator. So that's what this slide is talking about. And then the following slides really just go through the data elements for the Cactus data set. Just the different codes and element numbers for them. If we go through them.
And for the group, we kind of internally had some discussion about how technical to make these tables. I know for the line staff, seeing a EPCR code isn't super helpful. I'm inclined to leave it in, and an individual instructor can certainly take it out or hide the slide if it is not helpful or if it's too much information. Maybe an individual instructor might hide the right-hand slide part of that table and show the left-hand side of that table. But I also understand that the right-hand side of that table is probably more information than a lot of people receiving this instruction would need to know.
Just go through cardiac arrest and then talks about the shared database. And then going down to stroke. after the conversation in the last meeting, I don't know if we should type in here that this does not include duration, maybe? Since we sort of wanted that clarified, I don't know if this would be a good place to clarify that the time of onset and time of known well does not include duration.
Okay.
And then the promise or triage criteria is on the next slide. This one just highlights the idea that the drop-down boxes are important for the trauma center. They cannot pull this information from the narrative. States clearly. And then on the next slide, it's bolded. Going down, alcohol and drug use indicators. What it meant to define what constitutes this. I don't know if that was someone's note previously.
Yeah, we should strike that.
Links to injury prevention, so I wasn't sure what this slide referred to because it seemed to come after the trauma slide, so I wasn't sure if it came solely for trauma, but then it talks about if this is all in reference to alcohol and drug use indicators. And those bullets should all be moved over. I wasn't clear on how the slide was supposed to be set up. I felt like all refer to alcohol and drug use indicators. Does that seem correct to anyone who's seen this one previously?
Sorry, mute button. So some of this is related to our injury prevention work in the department. We have other programs that rely on broad alcohol drug use indicators, even though they are poorly defined. We have gotten some of these questions in the trauma registry users group because we know that they're kind of squishy definitions for whether or not someone was using a suspected alcohol or drug use. That's okay. The injury prevention programs still want this data. And so we have asked people to still essentially do their best. If it's suspected use, please continue to collect it because they will continue to use it for injury prevention, potentially substance abuse referral programs, and then it is tied to things like substance abuse referral grants or opioid grants.
So all of those bullets under alcohol and drug use should be moved over, correct? Because those are all sub-bullets of alcohol and drug use indicators, is sort of how I was reading it.
Yes.
We'll move all those over. And then in the next slide, it's another slide about some of the trauma data elements, about vital sign and GCS, pre-arrival notifications, date and time stamped. TBI, this is part of the EPIC study to improve patient outcomes for TBI. So 3 sets of vital signs, GCS, and end-tidal CO2. Glucose, advanced airway and type, and then patient contact and transport time. So just clarify the elements that were used for traumatic brain injury study. And codes for the pediatric and opioid data elements as well. That's the end of the presentation.
And then there are 2 slides in here that we left in that the individual instructor would want to hide or remove for agency-specific things, or the medical director for training that we left in, but the group could individually remove or decide to remove completely that we're looking at.
So did anyone going through that have any other additional comments or suggestions for improving this education PowerPoint?
So I know that was a whirlwind, and we just went through it very quickly.
Got translated into, we're not going to do it. You're not doing, we're not.
We will make the revisions that appeared on the slides in strike through in red. And then obviously assuming, so we'll, in a second, we'll take a motion to vote and then the group will decide if they want to vote to approve. Obviously, this is something the group can, we can post on the website if approved, reevaluate, and then make additional changes to at the next meeting or 2 meetings if we decide as Cactus evolves, if we need to make additional changes too, because I have a feeling as we learn with Cactus changes, what is effective and what is not effective, we will want to have an educational PowerPoint to help teach agencies how to improve their Cactus score. That may be this document. So my hunch is we will incorporate additional changes as we go forward into this document.
Mm-hmm. Yeah. So I'm happy to either table this, and if people want more time to review the changes, I can also take an amendment to approve the changes as they are today. So it's really kind of up to you guys how much time you feel you want to continue to look over this, but I'm happy either way.
Amber, it's Josh Baker. Sorry. I'm happy to make a motion to approve this as is. I should say with the changes.
Second.
Sharon Hollingsworth from Tucson, I second it.
Thank you. Is there any other discussion? Okay, we'll call this one for a vote. All in favor of accepting the changes as presented today, say aye.
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 Any opposed, say nay. Motion passes. I'll get those the document edited, and between me and Shelley, hopefully we'll get it all back to the group in a beautiful format. So the next discussion item, I don't know if Gail's back on yet. I don't think she's back on yet. Was to discuss, amend, approve the STR guidance document format versus training presentation format. So we had discussed this a little bit at the last meeting. Because of the large number of STRs that is likely to change in the rule writing, really the discussion was to potentially create educational documents such as PowerPoints that could be used to teach for the STRs rather than the long lengthy sort of bulleted document style that's existing right now. So if there's a motion to discuss this, we can kind of chat about this one a little bit more.
So moved, Brian.
Second, Orlando.
Someone's got music playing. Okay, thank you. So I don't know, Ben, have you and Gail chatted about this anymore? Or has anybody else thought about what what format we might want this scope of practice skills to evolve into, if we want to change it from what it is now, which is just a PDF of the required training.
Yes, unfortunately, I would like Gail to comment. Let me text her real quick and see if she is either still on the phone or thinks she will be back shortly. Give me just 1 second.
Okay.
Gail says she needs 5 minutes, so parliamentarian, can we take a 5-minute recess?
Yes, that sounds fine.
Okay, or Shelley says we can, Shelley says she'd like to skip something to something else we can on the agenda and come back. Okay.
Yeah, I don't think I have, the only thing I have on the agenda is current events, which I think have all been canceled. So we'll take a 5-minute break and wait for Gail.
Respectfully request we hit item number 6, agenda items to be considered for the next meeting.
Agenda items for the next meeting.
Why we pay Shelley the big bucks.
Hearing none. Hearing none, we can move on to item number 7, call to the public.
Anyone have a call to the public? Okay, with that, we can move on to some current events. I think, Shelley, in your most recent document, most of these had been canceled.
I'm sure everything's canceled. Yeah.
Yes, everything is canceled.
Gail says she's walking back over from the EOC, so she'll be back in about 4 minutes.
Oh, good. Perfect.
There's a metal detector at this building, so it's not like I can just run in.
Yeah.
Hi, Shelley. This is Orlando. I'm on the phone, so I just wanted to make sure.
Oh, hi, Orlando. Do you have anything for agenda items or call to the public, Orlando?
Well, you know, we're working remotely.
COVID.
Yes, yes, yes.
Okay, so no current events. Our next meeting is going to be July 16th. I think sort of to be determined location. Hopefully we'll be back at the DHS by July.
Fingers crossed. The EOC expanded this week, so.
Wrong direction.
Trains are going.
All right, she's through the metal detector.
You know, just a quick conversation. When we do these PowerPoint slides or whatever we do with the STRs, are we using DHS logo on this, or is it just generic?
That's a good question.
We post it with the DHS logo, but they can take it and make it theirs.
Take the logo off. Okay. Were you able to hear that? So it sounds like we post it with the DHS logo, but there's no harm in taking the DHS logo off.
I gotcha.
Okay. We stole your microphone too. Okay. So we, we're ready to discuss SDR format.
I think this is something that we were talking about, whether or not we work on right now versus postponing until scope of practice. I'm just sorry, trying to get on the computer here. Amber, are you on the phone still?
Yeah. We have open for discussion the agenda item to discuss the STR format.
So I think the question is going to be, once we get the scope of practice update, is determining the actual number of STRs. I know there was a concern the last time around brought forward, which is that it takes quite a bit of time to create a PowerPoint. I think the group felt that the PowerPoint format was probably more beneficial, but it was going to be kind of dependent on how many STRs we needed to build them for. I think that was kind of one of the big discussion pieces that we had the last time. I think the hope was to open scope of practice sometime this summer. Everything is kind of in a holding pattern right now with everything COVID related. So depending on how things play out in the next few weeks, we may have a better idea of where we're going with potentially getting to open scope of practice. But I don't know that that's something we can necessarily answer today. So I think unfortunately when we built this agenda, we were hoping to have a better answer as to what direction we are going. But just kind of right now we're in a little bit of a holding mode.
So would you want to table this discussion, maybe again until the summer when we have a little bit better idea whether or not those rules will open when we think they will?
Yes, that would be my recommendation if the group is okay with that.
Okay.
I would like to table this until we know we're going to start looking at the scope of practice, because there's a lot of stuff in here.
A motion from Brian.
That's a motion for me.
Okay. Do I have a second to table this one more time, maybe? Okay, so all in favor of tabling the discussion about the format of the scope of practice document, say aye.
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 Aye. Aye.
Okay, any opposed? Okay, the motion passes. We'll table this and keep it as a future agenda item once we determine, what the timeline is for opening the rules to address the scope of practice. And with that, I don't have anything else left on the agenda. Reminder, July 16th, we'll keep everyone updated of the location. And if no one else has come up with any other call to the public, we didn't have any earlier. Gail, do you have anything else you wanted to mention before we adjourn?
No, I apologize that I had to step away for another meeting. It sounds like you guys got through the PowerPoint for the Cactus.
Yeah.
Okay, excellent.
Thank you all.
Yes, thank you guys for
Absolutely.
being patient with me there.
With that, we'll adjourn and wait for the next meeting. Thank you, everybody.
Thank you.
Thank you.